But I do rise to speak today in support of the Abortion Legislation Reform Bill 2023, and I would like to, from the very beginning, acknowledge the leadership of the Minister for Health, the Honourable Amber-Jade Sanderson, in bringing this legislation to this House. Legislation that would change people's lives and bring dignity, privacy and safety for pregnant people in accessing abortion care, which is, of course, health care. I want to reflect on the experience of abortion across various generations to highlight that we stand here with and for all of those who have come before us. Yes, the activists, the legislators, the healthcare providers, but also all of the ordinary women who have accessed abortion when it was variously illegal and decriminalised, at times dangerous and unsafe. A friend of mine in her late 50s never got to meet her grandmother. She died as the result of a backyard abortion, the only really accessible form of abortion available at that time. And she left behind 6 children, 3 boys who went to an orphanage and 3 girls who went to the care of their grandmother. As a 23-year-old, I had an abortion that was illegal and safe. Our contraception failed and I was on medication that made a pregnancy unviable. I was in the privileged position of being able to afford that termination in the same week that I found out that I was pregnant. We made that decision as a very young couple and as a mother and a father to that baby, and not continuing that unplanned pregnancy was the right decision for us to make. But these are the very ordinary events that lead people to abortion care. 2 years later, as a 25-year-old, I stood on the steps here at Parliament House in support of the Honourable Cheryl Davenport's private member's bill, the Criminal Code Amendment Abortion Bill 1998. The bill saw abortion decriminalised, and I thank her and others who at that time overcame many moral and legislative obstacles to make abortion more accessible for the women of Western Australia. In the 25 years since the 1998 reforms, other Australian jurisdictions have caught up with Western Australia and in many cases provided for more compassionate access to abortion that better reflects contemporary clinical practice. In the 25 years since, I've continued to work as a social worker, including at King Edward Memorial Hospital, walking alongside pregnant people as they made choices about their reproductive health. Choices, however, which did not solely belong to them. Choices which others, in some cases, got to veto and make judgment over. There is no equivalent men's health decision that has the same kind of scrutiny or barriers than women's health decisions over their own reproductive rights, over our own reproductive rights. I have spent my entire career working to right the wrongs of gender injustice, and so now, in my 50th decade, I stand here proudly in support of the entirety of the reforms contained in this bill. I stand here to say that abortion care is health care, that people should always be at the centre of decisions about their health and their bodies, including their reproductive health, that those decisions belong between a person and their health practitioner, and that the health care that we need should always be available in our own state. I also stand here as the mother of a 14-year-old girl, and the changes in this bill will mean that should she ever need an abortion, she will be able to access it with greater ease, with less judgment, with more dignity, with greater privacy, and reflecting her existing capacity to make decisions about her own body, her own future, and her own reproductive health. In my contribution, I want to cover briefly some of the changes to abortion care in these reforms, and through the story of Pippa, a much-loved daughter, to highlight the travesty and trauma that the current restrictions on late-term abortions create for women and their families. An important change for all people seeking an abortion at any gestation up to 23 weeks is the removal of mandated counselling to obtain informed consent. As it is, good professional clinical practice requires informed consent to be sought and made for all health interventions. Now, of course, as a social worker, I know the benefits of counselling when it's in the right place and at the request and the need of the people concerned. Counselling around the decision to have an abortion will, under these reforms, become an individual's choice based on their own needs and circumstances, which they, of course, know and understand for themselves. The requirement for counselling can also create delays in people accessing an abortion. Not only does this delay disrespect a woman's decision, delays may also change the type of medical intervention required for a safe and effective abortion, particularly if those delays take a woman past the point of a medical termination and requiring instead a surgical abortion. This change respects that we have the right, the ability and the capacity to make decisions about our own health care. The bill will also remove the requirement for an abortion to be considered by two medical practitioners, the medical practitioner performing the abortion and another. This is the only routine medical intervention where this is required for adults, and again, there is no equivalent in men's health, including their reproductive health. Doctors already have professional standards of care and practice in place, commitments to an ethical framework and ongoing professional development. One doctor is perfectly sufficient to provide appropriate care. This also makes abortion more accessible and removes an additional expense for people seeking a termination, and means the intervention can be carried out in a more timely manner. This is particularly important for women in regional areas where accessing one, let alone two doctors, can be a difficult and a long process. The bill clarifies that both medical practitioners and students may refuse to participate in an abortion. However, they will be required to immediately disclose their objection and provide clear and unambiguous and timely directions to refer the patient to another health practitioner. And while this action is, of course, itself important, I do not think it's a professional's place to pass moral judgment on others. It is the woman and her family that will bear any impact of an abortion, not the doctor or healthcare providers. Doctors have a responsibility to act professionally and non-judgmentally at all times, and it is the hope that any required referrals will happen in such a manner. Currently, a patient whose general practitioner refuses to participate in their abortion care may find themselves required to see several medical practitioners before they find one that is willing and able to participate in their abortion care. Not only does this place the burden of the search on the patient, including potentially an additional financial burden, if the objection has been delivered in such a way as to create fear or judgment, it may create a sense of unwillingness to make an approach to another doctor. As I said earlier, I am the mother of a 14-year-old girl, and I do hope that she is as clear as I am that if she ever needs an abortion, that she can come to me and that we will navigate that together if that's what she so wishes. However, she already has her own GP, who she sees independent of me, as is developmentally appropriate. I respect her ability to make decisions about not just her body, but her future as well. And again, doctors are well equipped to make these assessments about whether someone is a mature minor, and they make these decisions already in a variety of health settings and circumstances, not just in abortion care. Under common law, the mature minor is deemed to be sufficiently mature and intelligent to make health care decisions on their own behalf, including consenting to medical treatment. And doctors are also invested professionally in ensuring that those assessments are appropriate to the young person in front of them. Finally, I would like to speak to the changes that this legislation will see to the provision of late-term abortions for Western Australians. Late-term abortions are very rare, accounting for less than 1% of all procedures, and are only performed in a hospital setting by appropriately trained medical practitioners. They occur most often due to the discovery of a serious fetal anomaly or because of a serious risk to the parent's own health. It is almost always a very difficult decision to make, as most women who have got to 20 weeks gestation expect to and anticipate taking home a live baby. Compounding that existing difficult decision is the complexity and indeed the trauma that our current regime can create. The bill before us removes the constraint that currently exists under the Health Miscellaneous Provisions Act on patients seeking late-term abortions, that is, currently abortions after 20 weeks. As it stands now, a patient must seek approval from both their original medical practitioner and then obtain joint authorisation from another two medical practitioners who are members of a statutory panel appointed by the Minister for Health. To demonstrate what our current regime inflicts upon families, I would like to share with the Chamber the story of Pippa, a much-loved and wanted fourth child, a daughter, a granddaughter, a sister and a niece. In October 2020, Pippa's family discovered that their much-wanted fourth child was on their way. From the beginning, it was evident that this was going to be a difficult pregnancy. There were multiple scans, 2 significant bleeds, and review of those scans and tests by 4 obstetricians in the private health system. However, no fetal anomalies were identified until the 20-week ultrasound. 20 weeks is the gestational recommendation for a fully comprehensive anatomy ultrasound to be performed. Until this gestation, many anomalies cannot be identified. Some, in fact, cannot be identified until a later gestation again. At 20 weeks and 1 day, a scan for Pippa with a maternal fetal specialist was done. The next day, a meeting with a maternal fetal specialist and discussion of the ministerial panel was held with Pippa's parents. And despite the multiple tests and detection of anomalies, no formal diagnosis or firm diagnosis was able to be made for Pippa. Instead, her diagnosis was described as grey. And despite seeking advice from maternal health specialists, no one could provide Pippa's parents any clarity on the health of the pregnancy. However, even at this time, the couple's right to make a decision within Western Australia had already ceased. 3 days later, the ministerial panel refused the couple's request for time to analyse the complexities of their baby's condition and a possible abortion. At 20 weeks and 6 days, an amniocentesis was completed. However, those results would take 3 to 4 weeks to arrive. The couple were not afforded the time to determine what was wrong with their baby and what disabilities they may or may not have. The next week for them became a frantic and an endless search for options, making appointments, putting decisions about their baby's future into others' hands, and ultimately arranging to travel interstate to have their pregnancy terminated. At 21 weeks pregnant, the couple were on a plane, and Pippa was delivered at 21 weeks plus 5 days. The panel made a decision on this couple's behalf, on Pippa's behalf. They left this family with no choices. There were no rights of appeal. There is no other health decision that is taken out of the hands of individuals, out of the hands of others who care about them, and are instead made by an anonymous group of people with no ability to have your point of view heard, your wishes respected, no right of repeal, and no recourse. And I quote from Pippa's mother, "At this point, I feel I fell out of the system. I was no longer being provided care by my private obstetrician, but I was also not in the WA public system. No one counselled me. No one let me know what could happen, where and when. There were frantic calls to Darwin to see if I could deliver my baby there. Thankfully, although they could not help me, they had the compassion to assist where they could and the sympathy to follow up with conversations. I was forced to exit the state, to attend a clinic alone without support, to deliver my desperately wanted baby in a setting that was completely inappropriate." The requirement to travel interstate cost the couple over $10,000. The family live in close proximity to King Edward Memorial Hospital, yet due to the ministerial panel and existing West Australian legislation, they were required instead to travel 4,313 kilometres to another clinic. The policies of the service performing the abortion over East were that men were not permitted on the premises. So Pippa's mother delivered her alone while her father waited outside. Pippa's father never got to see her or hold her. He didn't get to comfort his wife, nor she him. Pippa's mother says that the nurses and the doctors were the most kind, compassionate and understanding individuals, and she will be truly grateful for their compassionate care. Unfortunately, it was still a deeply traumatic experience. My much wanted baby died that day. I walked home to our hotel, sore and bleeding, to a foreign hotel bed. I didn't sleep. Knowing, of course, her own birth history, Pippa's mother had asked the clinic what to do in the event of a bleed and was told to Google the nearest emergency department, as the clinic did not have the capacity to provide any aftercare. To add another layer of complexity, this happened during the height of COVID, and Victoria and New South Wales were in lockdown. Only South Australian residents could have an abortion in that state, which left Queensland and Darwin. Darwin has a 24-week cut-off for abortions, but would only accept the couple if there were no other options available, as they were also struggling to cope with COVID hospitalisations. Queensland would allow a Western Australian in a clinic for a surgical termination, but only up to 21 weeks and 6 days. This left the couple, again, very little time, and to access the service during COVID, the couple required permission to travel and had to quarantine upon their return home without their family around them. Under the reforms we are discussing now, Pippa would have been delivered at King Edward Memorial Hospital. Her parents would have had another 1 to 2 weeks to make a decision of their own, to involve their family and children, and to be free to begin their grieving process. Pippa's parents could have been together as she was delivered, as they were for their 3 other children. I will leave Pippa's mother with the final words to Pippa's story. My husband never met our daughter. He never held her. He never saw how she looked like our second, a sweet, beautiful wee thing. We didn't collect her ashes. We didn't know that we could. I should have been at King Edward Memorial Hospital with my husband and then home to my own bed. Instead, after 2 days of blur, we flew home to our children to explain that our baby had died, and my life will never be the same. And so it is for all the Pippas, for all the mothers and the fathers who have come before us, for the women who have accessed abortion that is illegal, unsafe and even dangerous and traumatic. I commend this bill to the House.